Good morning. You guys are the strong. You've survived Vegas. You came to the bladder cancer course. This course has been running for many years now. I'm not sure what we're up to, 5, 6, 7, 8, but we've changed the course over time, and it's hopefully a high-yield, case-based walk through non-muscle invasive bladder cancer guidelines with some of the new developments that have occurred in recent years. A lot happening in the space of non-muscle invasive bladder cancer and a lot to keep up with. We are definitely open to any questions throughout. We request that you use the mic, and this should be a great course for you all. I'm Kristen Scarpato. I'm a urologist at Vanderbilt, and I am joined today by Dr. Jim McKiernan from Columbia, New York City, Dr. Seema Porton from UCSF. We have Dr. Chad Rich from University of Miami, and Dr. Chris Anderson from Columbia. All right, we are going to get started. Just a couple more announcements. As you all know, we are using an app for this meeting. The AUA 2025 Annual Meeting mobile app is available and free to download. When you download the app, you'll be asked for a username and a password. All course materials are available on the AUA 2025 website and mobile app. Use the email that you use to register, and your password is your AUA ID. As part of its disclosure policy, the AUA determines whether disclosed relationships with any ACCME-defined ineligible companies are relevant to the educational content of the CME session and mitigates any conflicts of interest prior to that session. You can see the full disclosure policy and any relevant financial relationships on the AUA annual meeting website, and you can claim CME for this. Please ensure that you log into the CME credit claim site to confirm that this session has been added to your record, and just please silence your cell phones. All right, so here's our course outline. We will, as I said, use the AUA guidelines as kind of a framework as we talk through some treatment dilemmas and challenging cases. Hopefully by the end of this session, you feel that you can confidently apply the updated guidelines as they were recently updated to risk stratify patients with non-muscle invasive bladder cancer, to adapt treatment choices according to risk, including the availability of BCG and any newly available treatment options, individualize a patient's surveillance needs based on their risk stratification, and counsel and manage them in the setting of BCG unresponsive disease, which we all know is quite a challenge and a hot topic. So the guideline was updated in 2024, and updates are particularly in the areas of diagnostics, therapeutic options, surveillance strategies, and imaging techniques. The purpose of the guideline is for us to be able to limit recurrence and progression through risk-stratified clinical framework in the management of these patients. So you'll hear, and we'll start off talking about risk stratification. That's really such a critical part in the management of these patients because it determines how we follow them, what options are available for them. We will be talking today about this group of patients, those listed in the top here, using the staging system, so TA, non-invasive papillary carcinoma, carcinoma in situ, and T1 tumors. The WHO has a classification for non-muscle invasive bladder cancer. Right now, we're using a high-grade, low-grade system. That's not necessarily universal throughout the world, but in the US, we primarily use that. It makes sense that if you have 2 buckets instead of 3 or more buckets, there can be some heterogeneity across risk stratification, and that's particularly important, I think, when we're talking about intermediate risk non-muscle invasive bladder cancer patients, and we'll go through a case that encompasses that. All right, so now we're going to have Dr. Rich come up and take us through risk stratification using a case.
Great. Good morning, everyone. Thanks, Dr. Scarpato and team. First of all, thank you guys for making it this early in the morning on the last day. The few, the brave, sticking around. I also see some friends in the audience. Thank you. The check is in the mail. All right. So as Dr. Scarpato mentioned, we're going to kind of use the guidelines with a case presentation format. And like for me, when I read guidelines, it helps to have a clinical case for me to remember the steps to go through. So that's kind of how we set it up here rather than reading the guidelines and just sort of talking. So this is a 68-year-old male who presents with asymptomatic gross hematuria, typical patient, history of tobacco smoking, no family history of any GU malignancy, and then they undergo an office flexible cystoscopy. Cytology is atypical. So the office cystoscopy reveals, and take note of how all these things are sort of laid out, because this is lines itself with the guidelines about how we should be describing our tumors. So there's 2 small papillary appearing tumors. We describe tumor number 1, posterior wall, about 2 centimeters. Tumor number 2, right lateral wall, approximately 1 centimeter. And then we comment prostatic and anterior urethra are unremarkable. The rest of the bladder mucosa is unremarkable. So really delineating each of the tumors, where they are, the size, etc. And this is obviously very subjective, the size, but you all do cystoscopies. You can kind of guess what the size is by looking after a number of years of experience. And then, of course, we do upper tract imaging. So CT urogram demonstrates normal upper urinary tract and fill-in defect consistent with the tumors in the bladder. So undergoes cystoscopy, and the TURBT, the final pathology report, is, as it should be, very descriptive. You biopsy the posterior wall tumor. It's non-invasive, high grade. Muscularis propria is present and uninvolved. I typically will do a deep bladder biopsy for these lesions, especially if I'm thinking it looks high grade apparent to me. I'm very meticulous about getting muscle. In this case, the fibers of muscularis propria are present and not involved. The right lateral wall tumor, essentially the same thing. High grade TA, muscularis propria is not present in that one, but because I do those deep biopsies, at least I have my backup. So the muscularis propria in that case was present and uninvolved. So again, being very descriptive. And the purpose of that case is to essentially illustrate the first 3 guidelines, which very basic things that we all agree on. That's why they're clinical principles as per the guidelines nomenclature. But number 1, at the time of resection of a suspected bladder cancer, clinicians should perform a thorough cystoscopic examination of the entire urethra and the bladder that evaluates and documents tumor size, location, configuration, number, and mucosal abnormalities. Number 2, at initial diagnosis of a patient with bladder cancer, a clinician should perform complete visual resection of the bladder tumors when technically feasible. And I'll pause for a second on this one, because right there in red is the reason why this clinical principle is up front, because, especially at high volume centers, referral cases that come in, you scope them again and you'll see a tumor and you're thinking, is this a recurrence? Is this a new tumor? A lot of times it's just residual unresected tumor. So that 45% of patients, who have residual tumor, sometimes it can be misleading and you can think, okay, this is a recurrence because they had something, but it's possible that they were incompletely resected, got intravesical therapy, and then are told they have a recurrence, but it's just because there was, I don't want to say poor, but incomplete initial resection. So when you see bladder tumors, initial resection, try to be as complete as possible. And then the third one, a clinician should perform upper urinary tract imaging as a component of the initial evaluation of a patient with bladder cancer. Again, clinical principle, but stage them initially there in the upper tracts. So the patient undergoes a TURBT. The pathology, as we discussed, reveals 2 high-grade TA non-invasive papillary tumors. So Dr. Scarpato briefly touched on this and the importance of risk stratification. The next question you should be asking yourself, as per the guidelines, is what's this patient's risk group? So as you've staged them, you've done the resection, now you're like, okay, how am I going to treat them? And that's where risk stratification is important. So the guideline specifically says, at the time of each occurrence and recurrence, a clinician should assign a clinical stage and classify a patient accordingly as low, intermediate, or high risk, and we'll show you what those groupings are. And a lot of this is largely based on sort of landmark studies done in the EORTC and the Spanish Urologic Oncology Club, Cueto. which they looked at tumor size, focality, grade, and stage. And then the AUA and SUO expanded upon that by adding in things that we felt were important in terms of prognosis, such as lymphovascular invasion, prostatic urethral involvement, variant histology, and whether or not they had a response to BCG. So expanding upon that model, that's how we came up with the risk stratification system. And again, just as a historical perspective, the EORTC and Kuwaito models are good, and based on clinical data, solid data from a number of non-muscle invasive bladder cancer trials done many years ago. A lot of these trials were from the late 90s, early 2000s. But the limitations are, a lot of them didn't have maintenance BCG being used. A lot of the patients didn't undergo restaging TURBT or didn't have perioperative chemotherapy. So the applicability in today's cases may not be, as good as it was compared to the past. So when you look at what's called the C index, which is essentially the measure of concordance, and a flip of a coin is 50-50, 0.5. These models are moderate to fair in terms of the C index, 0.6, 0.7. So good, but not great. Now, in terms of the risk stratification, so these are the groups here. So pay attention to this slide, because this is one take home that you really want to, go away with and feel comfortable. Low risk is a small, solitary, low-grade tumor. That's the easiest one, first time. And then this category called pun lump, which a lot of us may or may not see, just depending on, your referral patterns, but that's a low-risk bladder tumor. Intermediate risk is basically a recurrent low-grade tumor, recurrent within a year, or multifocal big low-grade tumors. And then this one is a little bit, can catch people off guard, because there is a high-grade category in the intermediate risk group. Those are patients with a small solitary high-grade tumor, less than or equal to 3 centimeters. And then another one that can kind of catch people off guard is you see this T1, but it's a low-grade T1, a very rare entity, but at the same time, the AUA, SUO felt that the outcomes are more aligned with intermediate risk. And, we can spend a whole hour debating, whether high grade should be here or not, but take it for what it's worth. This is where high grade solitary small tumors lie, intermediate risk. High risk is, as we would expect, large, bulky, high grade tumors, superficially invasive to the lamina propria. If they're multifocal, if they're CIS, if you had BCG and it came back afterwards. Variant histology is another important one. So, your pathologist should be reporting on that if it's present. And then lymphovascular invasion or high-grade prostatic urethral involvement. And then, we looked at this in our cohort at the University of Miami, just showing that the AUA risk groups do stratify patients appropriately in terms of recurrence and progression. And I had mentioned the C index for the EORTC and Kuwaito models. So we calculated the C index for the AUA SUO, and it was pretty similar, 0.6 to 0.7. So, this is the risk stratification tool that we use. There are a number of different ways you can risk stratify. You can do it from your head. If you happen to remember that whole chart I showed you, the AUA actually has a nice framework where you can sort of run this algorithm and look at it on the paper. There's an EORTC risk calculator. We developed, just for illustrative purposes, this app. It's free online. I get no money for it, full disclaimer. You can just go to blatter.com, and if you aren't sure, you plug in all the parameters. So like in this case, initial tumor, TURBT, less than or equal to 3 centimeters. It's TA, high grade, multifocal, and then the app or the website will calculate it for you, and it will tell you that it's a high risk because it's multifocal, high grade TA. So there are a number of other ways to do this, but this is just one free, simple way online. So in this case, as I mentioned, the patient's high risk, non-muscle invasives, because he's high grade, multifocal. All right, we're going to go on to another case. So the first few guidelines, again, just clinical principles about how you manage an initial presentation and then how to risk stratify at each occurrence and recurrence. So now for this case, we're going to talk about variant histology. This is a 72-year-old male referred for bladder cancer, had a cysto TURBT outside, referred in, And the path just on the surface looks pretty bad. It's high-grade urothelial with invasion of lamina propria with poorly differentiated features, scant muscle fibers present and uninvolved. So it's kind of like the pathologist is saying, this looks funky. It's somewhat invasive. So that should trigger, a signal to you to say, maybe, as per guidelines, an experienced genitourinary pathologist should review the pathology of a patient with any doubt in regard to variant or suspected variant histology. So the poorly differentiated is your buzzword. That's the doubt right there. So they should be looking for these variants: micropapillary, plasmacytoid, neuroendocrine, etc. Why? Because these patients ultimately can harbor occult muscle invasive disease, and their prognosis is very different from, non-variant pure urothelial carcinoma. So in this case, we had our pathologist review it, and they found high-grade urothelial carcinoma with plasmacytoid features. Again, this is a bad actor. In fact, some of these patients may have non-muscle invasive but still have positive lymph nodes. The carcinoma invades the lamina propria. Fortunately, in this case, muscularis propria was present and uninvolved. So again, take home here is to have your pathologist review. If there's any doubt, take a second look and specifically ask them, did you see any variant histology? All right, and then wrapping up the last variant histology guideline statements. So as I mentioned, these are bad actors. So if you're planning a bladder sparing approach, if you're going to use, intravesical therapy in a variant histology, then you should definitely perform a restaging TURBT. The rate of occult muscle invasion is significantly higher in these patients, so you want to make sure you don't miss muscle invasive disease. So definitely re-TUR them. And the other thing to consider, and again, there's other cases that we'll discuss about when to offer an early or timely cystectomy. But if you see variant histology, you need to be talking to the patient about the likelihood of needing to undergo radical cystectomy. So in his case, that's where it ended up. He was consulted on the options and elected to proceed with a radical cystectomy because of the variant histology. I think this was... Well, we'll do I guess we can do a question to the panel, or oh, there's a poll there. Okay, all right. So I'll answer it for myself, for you guys anyway. Which of the following is not considered variant histology in non-muscle invasive? So we have plasmacytoid, squamous differentiation, micropapillary, carcinoma in situ, or nested. And then let's see how this works. Oh yeah, there we go. All right, great. Everybody got it? Most people got it right. All right, so yes, carcinoma in situ is not considered a variant histology, whereas the others are variant histologies. So look out for those on your path reports. Okay, I think now I'm going to turn it over to Dr. Anderson, and we'll hear about urinary biomarkers. Thank you.
Good morning. My name is Chris Anderson. I'm a urologist at Columbia University in New York, and I'll take a few minutes here to talk about urinary biomarkers. These guidelines have several statements about the use of urinary biomarkers. I think this is a fascinating space and going to be an explosion of new products in this space too. So let's dive right in. Our current guidelines really summarized a handful of biomarkers that are listed here. You can see a lot of these have been around for a while. A lot of these are mostly protein-based. Sometimes a few are cellular-based as well. And then the new kid on the block is at the bottom, the CX bladder. And there are a huge amount of biomarkers that are currently in development or even available, commercially available in the States or in other parts of the world that have not been summarized in the guidelines. So we're going to kind of touch on, really focus on some of these new ones and kind of where we're headed. The guidelines specifically state, this is statement number 9 in the guidelines, that we should not be using urinary biomarkers in place of cystoscopy. Why is that? Well, at the time of this guideline review, based on the panel of markers that they had, really those markers did not perform well enough to be able to help reassure patients that they did not have recurrent bladder cancer. So as of this guideline, it was not appropriate to substitute cystoscopy for a biomarker for cystoscopy. The guideline does note that the CX bladder test is promising. We'll talk about kind of what that means. So this statement certainly may change at some point going forward with the next iteration. Statement 10, very important, that we should not be using these biomarkers at all for patients with low-grade disease. Many of us use cytology for surveillance of these patients, and that performs pretty poorly for low-grade bladder cancer, as do many of the other biomarkers. So we really should not be using those at all for patients who have low-grade cancer. Statement 11 talks about the fact that there may be some unique situations where these biomarkers can be useful. Specifically, Eurovision can help estimate response to BCG, kind of in a prognostic way, or adjudicate equivocal cytology. There's been a couple different products that have shown to be of value there. So let's dive in here. This is a case presentation. We all have patients like this. He's a 73-year-old patient who had high-grade TA and CIS that was given induction and maintenance BCG for 3 years. SWOG protocol. He's been NED, and he hates cystoscopies, right? Who hasn't had a patient that hates cystoscopies? A lot of patients do. And so he says, hey, doc, do I have to keep getting these cystoscopies? They're miserable. I hate them. And so you have to answer his question. What do we do? So this is an audience poll. Question for you all is, which, if any, biomarkers are you using to help with your surveillance of these patients? All right, let's see what everybody thinks. All right, what do we have? Yeah, okay, so kind of a smattering across the board. A lot of people aren't using any, and that would be largely appropriate based on what our current guidelines would suggest. And some people using CX, some people using FISH. Well, what is the current landscape? What could be used? What might be helpful? What's not helpful? I have no conflict of interest here. And why is this relevant? As I said, cystoscopy A is uncomfortable. It is invasive. It does have some risk, and it's not perfect. Cystoscopy is far from perfect, especially for detecting, low volume carcinoma in situ. The sensitivity may be around 70%. Cytology also not perfect. Very specific, meaning if you see a positive cytology, it almost always tells you that there's something going on. But the sensitivity is quite poor, including even for high-grade disease at maybe 50 or 60%. And this is the gold standard. This is as good as we are currently doing in the current practice. What do patients want? How good would a biomarker have to be to replace the current standard of care? Well, it have to be very good. In this study, where they asked a bunch of patients on surveillance for bladder cancer, how good would a biomarker need to be in order for us to not scope you? At least 90% accurate. More often 95%. So that sets the bar very, very high. And many of the biomarkers that the panel reviewed for the guideline actually came nowhere close to that bar, which is why it led to the current recommendation. So statement 9, we shouldn't be using these biomarkers instead of cystoscopies. But there's a whole bunch of new biomarkers coming down the pike. And I'll kind of try to summarize some of the newer ones that are mostly based on some sort of shed genetic material in the urine, whether it be RNA, DNA, or some sort of DNA methylation marker. So the RNA-based markers probably have the most data on them and have been around the longest, specifically CX Monitor. This is a product that has been around for several years. It's a high sensitivity test, meaning it's designed to capture as many patients who have recurrent bladder cancer as possible. It is based on the expression of 5 RNAs in the urine, one of which helps determine or rule out false positives due to inflammation. It's also combined with clinical data to give you an estimated risk of having a urothelial carcinoma. In the 2017 study, about 1/3 of patients on surveillance tested negative, and the sensitivity was over 90%, 92% specifically. Works a bit better for higher grade, higher risk tumors. It's been compared to other tests as well, specifically NMP22, cytology, and FISH, and probably outperformed all of them in this 800-patient cohort. So this has been available. It's certainly something that patients seem to be aware of, and many are asking about, and we are incorporating it into our practice as well. Expert bladder cancer, this is primarily available in Europe. It's more of a point-of-care test based on 5 RNAs in the urine. The test negative rate in this study was very, very high. Almost 3/4 of patients tested negative, but the sensitivity was considerably lower, overall about 75%, and works really best in high-grade disease. And I think you'll see that a lot looking at these different markers, that they perform well for high-grade disease, maybe not quite so well for low-grade disease, but are arguably better than some of the other markers like cytology and FISH. DNA methylation, there's a test called Bladder EpiCheck, which looks for 15 proprietary methylation signatures in voided urine. In this study, the vast majority of patients tested negative, but the sensitivity was kind of moderate in the 60s to 70% overall, but for high-grade cancer, close to 90%. And again, much better for high-grade recurrences than for low-grade. And then lastly, excuse me, there's a whole slew of DNA-based, cell-free DNA markers that have been published on and are currently actually part of several clinical trials and other protocols. These are four of the ones that I've listed here, but this is not an exhaustive list. Euromonitor is one such test. This is based on 3 commonly mutated genes in bladder cancer: TERT, FGFR3, and KRAS. In this study from a couple years ago, the sensitivity of the test was 87%. Specificity was almost 100%, which is kind of comparable to cytology. And the authors suggested that with the use of this test, you could avoid nearly 30 cystoscopies at the risk of missing 1 recurrence. So, it's kind of an interesting benchmark. EuroAmp, this is a product from Convergent Genomics. This now uses 60 different genes in voided urine. Sensitivity, kind of around 80%, again, much better for high-grade cancer. And, importantly, they've kind of asked some interesting questions with this product, including can it be prognostic for patients who have non-muscle invasive disease, who are getting intravesical therapy, or even assessing response to intravesical therapy. So I think there's a lot of really interesting questions that can be applied to, that these markers can be applied to, including this one here. And then lastly, the UCAP-Seq. This is a 460 panel gene panel, cell-free DNA test that had a sensitivity in the mid-80s, also very high specificity. And again, a lot of interesting applications to assessing minimal residual disease. This is also, as I said, incorporated into some ongoing trials. So I think we're going to see a lot more of these and other markers as well. But to go back to our case vignette, there are trials ongoing right now to answer the specific question, which is, can we use these markers instead of cystoscopy now that these markers are getting, into the 90% sensitivity? And I suspect that probably some of these are going to be positive trials. Certainly, we've seen that in the hematuria front. And the AUA has recognized this as well. They know that this is a very important future direction. This is written in the guidelines, where Statement 9 that says, no, you cannot replace a cysto with a biomarker. There's a good chance that that will be changed at some point with the advent of new and better performing tests. So bottom line is that we have a lot of interesting products here, some new ones. We're learning about them. We're learning how effective they are. They tend to perform best for high-grade tumors and can help at least 1/3 of patients avoid a cystoscopy. There's a lot of interesting questions that kind of follow the use of these tests, including how do you manage positive markers with negative cystoscopies? How can you, are these prognostic? Can you change cystoscopy intensity? What about the cost? What is the risk of missing low-grade cancer? So on and so forth. I mean, we could talk about these all day. But our patient actually was quite happy to have a negative biomarker 3 years out, and he elected to avoid a cystoscopy. So I think we will follow that up with a second response question. After having said all that, if you were faced with this patient in clinic, would it change your thought about what test you might be interested in using, or perhaps not at all? To the panel here, does anybody have any thoughts on the use of these tests, or?
Yeah, so I use CX Bladder Monitor a lot during COVID.
Yeah.
And that helped kind of reduce the number of people coming in when slots are limited for that. But the nice thing about it, it's a home test. So it gets mailed to the patient. They give a urine sample, and then it's mailed back in. And for that, that's nice. A lot of my patients travel 8 to 12 hours sometimes to come see us. And so that is, this has helped a lot. I just had a patient contact me yesterday. She's taking care of her very ill sister and is not in California. And she's trying to figure out, should I fly back for my cystoscopy? But my sister is dying from ovarian cancer kind of situation, and I don't know when she'll pass. And so we sent her a CX bladder monitor test. She loves her cystoscopies, and it gives her anxiety not to do a cystoscopy. And so this hopefully will let her focus on spending time with her family. So there's a lot of ways you can kind of work this in. One thing with the CX monitor test, though, when you look at the patients where it's probably safest for, it's the 6 months after initial diagnosis and 9 months if they had a recurrent tumor. And after that is the window that you can use this test in. It seems to work okay as long as it's 4 weeks from intravesical BCG. For intravesical chemotherapy, it doesn't really seem to impact or matter.
Yeah. Thank you very much. Jim? Yeah.
I think when we talk about these, and the guideline panel addressed it, to replace cystoscopy as though it's kind of an all or nothing, like you will stop doing cystoscopy and you will switch to biomarkers. And I think probably the most open window for integration is to alter the surveillance schedule, which has been around for 100+ years and is pretty much empirically derived, like every 3 months, et cetera. So having somebody go from 3 months to 6 months, a year early, who had a high-grade TA and never recurred, and skip one cystoscopy and insert a biomarker is probably the avenue that we're going to see things come into, as opposed to you're stopping doing cystoscopy for bladder cancer and you're switching to biomarkers.
Absolutely. Deferring cystoscopy.
De-intensification.
Yeah.
I just had a comment too about biomarkers for potentially predicting response to therapy. So right now we're talking about it as a way to maybe avoid a cystoscopy, and we see that either in patients who are undergoing hematuria workup, where we can potentially use biomarkers for low-risk patients there to forego cystoscopy, or now in surveillance or follow-up of patients. But we're seeing more development in terms of who might respond to BCG or not. And gosh, in the setting of BCG shortage and in the presence of all these available other agents that we now have for patients, a reliable marker that would predict response to therapy would be super high yield and great for our patients. And so hopefully we see some more development in that space. It makes sense because obviously the urothelium, the urine comes in contact with the urothelium, and so presumably something is shed there. We should be able to find a clue. There's some exciting work that was presented at this meeting regarding artificial intelligence with digital staining, and that's kind of biomarker-like. And so I think, next year at this course, we might be presenting some different data and different ways for us to use biomarkers.
No doubt. Right. All right, Dr. Porton.
Here. Okay, there we go. All right. So this section is kind of talking a little bit more on the role of repeat resection, which is slightly controversial and different across guidelines. And it does come up a lot, and then we'll kind of move into intravesical therapy. The mouse, okay. Okay, 72-year-old gentleman presents as a second opinion for new high-volume multifocal high-grade TA. 8 weeks ago, had a complete resection, and you had a pathology re-review at your institution that was high-grade TA, no muscle present, CT urogram, some thickening and filling defects, and upper tracts are remarkable, and has a typical history of a bladder cancer patient. So when you look at the AUA guidelines, there are 3 that kind of talk about repeat resection. So one is try to do a complete resection from the beginning. That makes sense. And if there's too much tumor volume, come back to repeat that and clear away all remaining tumor if technically feasible. Of course, if a bladder is 100% involved with CIS, that is not really possible to do, but anything visible that you find, you should resect. In a patient with high-risk, high-grade TA tumors, you can consider performing a repeat transurethral resection, and much of that is sometimes based on maybe you didn't do the first resection yourself, or when you did, the tumor volume was high, that you're a little worried that you would need to go back to completely clear things. The last one is a common one, and it shows up on many question banks, boards, etc. And that's when you have T1 disease, whether or not you have muscle the first time, that you go back and re-resect, because there is a possibility of upstaging to muscle invasive disease. So these are the different guideline recommendations for a re-TUR. I talk about this a lot with our residents, particularly when they're at VA and ZSFG or general hospital sites, because sometimes they're like, oh, well, this guideline says I don't need to go back and do this. And I'm like, well, actually, what did it look like the first time around? Maybe you want to consider going back and re-resecting. So the European guidelines really say you've got to go back, and that's based on muscle, right? So if there's no muscle, if you have high-grade TA or T1, you're going back. And that's even in a small, solitary TA tumor. If you don't have muscle in that specimen, they recommend you still go back, right? The AUA guidelines, we went over that. It's a little different. It's really based on, for a TA tumor, there's no mention of muscle being a requirement at that time. And most people go back primarily when there is large volume or multifocal. You can consider it. NCCN, it kind of is a conglomeration of EAU and AUA. And when you really look at that, they talk about you go back for high-grade disease if there's no muscle, and you go back if there's a high volume. And then, of course, for T1s, Canadians re-resect everybody, and very aggressively, it looks like, from their guidelines, and the others are a little bit more wishy-washy on that. But in terms of AUA guidelines, it does give you a little bit of leeway in clinical judgment in patients with high-grade TA disease. So why do we do re-TURBT? And really, it's about making sure that one part of it is making sure that you're getting the proper stage. If you look at all these three Kaplan-Meier curves, they are all about probability of recurrence, and across multiple studies, the whole top line is patients who have had re-TURBT. So it tends to support that in terms of appropriately risk stratifying, and then therefore that impacts adjuvant therapy, and therefore that impacts probability of recurrence, which makes sense. Something really interesting also came out from multiple recent studies on, does your TUR impact actual response to adjuvant therapy? So this was a trial. It was called the Nimbus study. The intent of this trial was to figure out if we can use less BCG during the BCG shortage. So that what they did actually is they cut the number of BCG given to patients. But the other interesting part of it is that you did a TUR and a re-TUR until you came back for that TUR having no evidence of disease. So most patients had 2 TURs and some had 3. And so when you look at patients who underwent induction and maintenance treatment, what's really interesting about this is that even though it was a negative study about being able to reduce BCG, but the recurrence rate in this study was 11% for some very, very high-risk disease at 2 years. And that's much lower than what's been reported in the literature in our standard cohorts of examining how well BCG works. And what they were able to figure out is it was the impact of good TURs and actually a re-TUR. So I think there's an oncologic benefit to re-resection. Another reason is that re-resection is able to help you get these other factors, like looking at T1 substage and identifying people who are very high risk per the EAU guidelines. So many reasons to do it based on multiple studies and guidelines. Why do I do it? I think it's important to definitely resect tumors. I do worry a lot about upstaging. Again, I think there is an impact on oncologic outcome. It's one of the most important things you do when you take care of a bladder cancer patient. It is not a sexy procedure that you can talk about, like cystectomy sometimes, and then you can, debate about all these intracorporeal things and all of these other issues. A good TURBT, you can probably make more of an oncologic impact for your patients than some of the attention we pay to cystectomy to some degree.
I just want to make a comment on that. I think I've heard Seema say before that she is, I'm probably going to say this incorrectly, but you are more high stress and less of a fun teacher when you're watching or working with your residents to do TURBTs than with cystectomies, because quality is so important. And there's been a lot of attention recently on the importance of TURBT. There's like a master class here at the AUA about how to optimize your TURBT. This is an area of urology where we've seen very little development with our technology in the past. And as you all know, it's like we are using rigid instruments in a sphere that is distensible, and it's just very challenging. And so there's now a backtable urology update on how to optimize your TURBT. The EAU educational program has one. I cannot say enough how I feel like this is a real case. Not only can you hurt patients if you don't do it correctly, this is often an older, sicker, comorbid population. There's been a lot published about anesthesia in this particular cohort and the complications associated with that. And then there's been a lot published in terms of quality metrics. So while it's something that all urologists are trained to do, we really should, I think, focus our efforts on doing a quality TURBT, visually removing everything we can see, getting muscle in our specimen, ablating or treating CIS, because that has real implications for these patients in terms of their risk stratification, their success with therapy. I've heard Dr. McKiernan say before that he's converted a BCG unresponder from an outside institution to a responder just by doing a more thorough TURBT and ablation of CIS. So I'll get off my hill here, but
that's completely true. I'll add to that. So CIS is sort of funny in its appearance and behavior. If you have a lot of CIS in the bladder, it can be pretty morbid trying to ablate or get rid of a lot of it. But and so in those cases, I try to do what I can, but not make it so that there's a bladder that I now can't put any intravesical therapy in. And that's a little bit of a balance. But there is CIS that's not flat. It is flatter than a papillary tumor, but if you notice a little mound, try to resect that CIS versus just biopsy it, because we've often found that there's something deeper. So the DNA mutations that happen in CIS are just maybe two more changes away from becoming a muscle invasive bladder cancer. So when you really look at the genomic precursors of these lesions, CIS actually has a very clear pathway through just couple more mutations into muscle invasive disease. So often you can find invasive disease under the CIS, which I often do. Timing, I usually do about 3 to 6 weeks after initial TUR. I sort of see how patients are doing in terms of recovery from the first TUR. I do use blue light for patients with high-risk disease if they haven't had it for their diagnostic TURBT, unless they're really against that additional catheterization prior to the procedure. So the next sort of set and case presentations is really going to talk about intravesical therapy. So this is a 70-year-old gentleman, gross hematuria for a couple months, a CTU, not super revealing. Cytology is negative. In an office cystoscopy, there's a small 2-centimeter papillary tumor on the left wall. You do a TURBT, it looks pretty complete, and it was an uncomplicated resection. So what are sort of next steps? So in a low-risk patient, I should say that I didn't give you guys the pathology on this, did I? It was low-grade TA. You don't need to do any adjuvant intravesical therapy. And so we're really talking about like low-risk sort of disease in this case, right? And this is where we get to the risk stratification. And in terms of next steps, this is where we work in just surveillance. And so that is getting a cystoscopy at 3 months after your TURBT and then at 1 year later. And then you can go annually to 5 years. And then after that, it's a conversation with the patient. And this usually goes pretty easily in terms of being able to completely de-intensify cystoscopy in this really low risk group. What should you do though, although you don't give adjuvant intravesical therapy, giving peri-op intravesical chemotherapy is indeed indicated in patients that you are suspecting have low-grade disease. So if someone has a clear cytology and a papillary tumor, I will usually use a single perioperative installation of gemcitabine. And that is supported by the data from SWOG by Dr. Messing in 2018, where they randomized about 400 patients with suspected low-grade disease to intravesical installation of gemcitabine versus saline. And this reduced the risk of recurrence and from about 35% for the folks who got gemcitabine and 47% who got saline, a hazard ratio of 0.6. I would say this is worth it for these patients. You know, where you don't want to push the gemcitabine is you do a massive, large resection, and you're very worried that this patient is going to be high risk and will need adjuvant intravesical therapy. In that case, sometimes the decision is, should I put the gemcitabine in now? If you notice the bladder is thin, or definitely if you have an overt perforation, or you've done a very large resection, the answer probably is it's not worth it. But in a single 2 centimeter papillary tumor, straightforward, gemcitabine does have a big impact and will help. There are other agents that you can use. There was a meta-analysis that's on the other side of the slide looking at epirubicin, thiotepa. These are historical drugs, and then mitomycin C. For us, mitomycin C is about 20 times more expensive to procure and use, and also the rates of chemical cystitis are much higher. So some of us have been traumatized by chemical cystitis from mitomycin C, and I really haven't seen that with the use of gemcitabine. One of my first TURs, young gentleman, I think it ended up being like pun lump or something even lower than low grade. That mitomycin chemical cystitis, I called my partner in because I was like, this cystoscopy looks horrible. And, you know, he recovered with steroids, et cetera. And after that, I was very afraid of mitomycin. Thank God now we have gemcitabine supported by a randomized clinical trial. I do use mitomycin a lot in adjuvant intravesical therapy. It seems to have less of that chemical cystitis when it's not so close to the TUR. So I'm going to change up the case a little bit here. Same type of patient, a little bit bigger tumor. And then plus there's 6 small tumors across the trigone. So this is a lot larger tumor volume. And so you end up getting rid of the tumors using a mix of a TURBT and cold cut biopsy. It appears to be complete. But in this case, there is high-grade TA, muscle is present and uninvolved. And the question is, would you repeat the resection? And I think this is where you have that leeway with a little bit of a judgment. Generally, if there's 6 small papillary tumors, I go back and look at that CT urogram and I worry that there could be upper tract. You know, when there's upper tract disease and you get droppings in the bladder, it's kind of around the trigone bladder neck, but there is a distribution that looks a lot more like, hey, this looks like it's coming from the upper tract or not. So I go back and make sure that's not happening. And so sometimes I will re-resect. In this patient, if I did the first re-resection, I may not if I felt like I cleared it well. And so what are next steps? So when you have a high-risk patient, so this is high-grade TA multifocal disease for this gentleman, but anybody with CIS T1 or a high-risk TA, you really should be looking at adjuvant intravesical therapy, and this should be BCG. And another one of our faculty will discuss what happens during a shortage, but in the absence of a shortage, BCG really is the standard of care adjuvant treatment for high-risk non-muscle invasive bladder cancer. There's not sufficient evidence to recommend one strain over another. There's been a lot of mouse model and also in-human studies that look at the different strains. In the end, they get to the same immune activation, but they may do so a little differently. And that's the only kind of nuance between the strains. Right now in the US, we just have TICE BCG. Perhaps when some of the when 1602, which is another huge cooperative group study looking at a Tokyo strain, results out, we'll have another strain of BCG. You guys might have seen some press about access to recombinant BCG. So this has only had phase 1 or phase 2 studies, and it's part of an early access program. So it is still a study, but it does get you BCG, and some of this older data kind of supports that maybe strain doesn't matter. And so it's one avenue to reduce a shortage. In terms of strength of BCG, some large trials were done in Europe looking at whether you can reduce the actual dose for patients in terms of induction and maintenance. And so there was 4 arms to the study. These were all high-grade TA or T1 patients. There was no CIS in their 1,000-patient study, but the 4 arms were: do you do induction and maintenance at full dose for 3 years, induction and maintenance at full dose for 1 year, induction and maintenance at a third dose for 3 years, and then, or just for 1 year. And for high-risk disease, really, you should do full dose for the 3 years. For intermediate risk disease in the AUA guidelines, that is primarily the high-grade TA, because we don't recommend BCG for low-grade disease. So that's the tiny high-grade TA, which represents about 5% of all newly diagnosed bladder cancer. So you don't see it often. So that's in that group. But for these high-risk patients, I think trying to get through the full treatment regimen is important. Usually we don't combine BCG with other agents. There's a lot of trials going on, but nothing yet that we can hang our hat on. Once someone has induction BCG and you do that cystoscopy, you definitely should continue with maintenance BCG based on availability for 3 years is tolerated. So that's at month 6, and then it increases in 6-month intervals. So then 12, 18, 24, and 30 for a total of 27 treatments. This can be pretty confusing. One thing that we do is we have a little chart where a patient can write in the dates of their cystos, and we have it kind of timed out. This also helps them plan their life when they're going to have a 3-year treatment of multiple doctor visits. And so in that way, they can visually see the timing of their anticipated BCGs as long as the cystoscopies in between remain clear, and that's helped people stay on schedule. This is just a study that Dr. Kamat and I did, kind of looking at the literature of do you really got to do maintenance BCG? And in the end, yes, you do. The top blue curve and the red curve, looking at maintenance with T and T1 and CIS, really show better percent at reducing recurrence as well as progression than any other induction maintenance regimen or absence of maintenance that you can come up with. And so what about the BCG shortage? So I'm going to pass this over to Dr. McKiernan.
Thanks. Thank you, Seema. Appreciate it. And thank you to the panel for keeping me a senior member involved with all these talented presenters. I really appreciate that, and everything that Dr. Scarpato has done to take on the leadership of this course has been great. Before I do this, we're going to move a little bit now into pharmacoeconomics, which I'll admit I'm not an expert in. We'll talk a little bit about the drivers of BCG shortage. I want to go back maybe to a comment earlier regarding re-resection and the role of re-resection, that randomized trial of multiple re-resections. I think it's underappreciated. Kristen alluded to the concept of BCG unresponsiveness versus what I will sometimes unpopularly refer to as urologist unresponsive bladder cancer. And that's people who are identified as having not responded to a drug because, in fact, they didn't respond to a cystoscopy or a TUR. And differentiating those two groups is something that I think really deserves our attention. And I think one of the drivers for not recommending a re-TUR, which is sort of a social doctor-patient contract, is that it's difficult to tell someone who's just been diagnosed with cancer that you need to repeat the operation that you just did on them because it's likely you didn't do it well enough. And that's actually the conversation that you have to start before you schedule a re-TUR. And it's always been my practice to tell people that prior to whenever I have the opportunity, prior to the first TUR. To say, we're going to go in and do an operation on you. There's a couple outcomes. One of them might be, the possibility that we have to do it again as a double check in about 4 to 6 weeks and plant that seed at that level. And then when the path comes back, stress that it actually doesn't require cystectomy. That's the good news. But we do have to go do what I told you about last month, which is go back and check to make sure we got it all. 100% acceptance for most patients. Whereas when you come in and say, you have cancer, and I think I may have left some behind, we need to go back and do it again. 100% likelihood of a second opinion. The patient's going to say, what? I need to go to a different doctor. So I think people oftentimes don't stress re-TUR when it's appropriate because they don't want to have that conversation. Just an editorial comment, not in the slides, not supported by any guideline statement. All right, so BCG shortage, just without audience response, how many people here have experienced some impact in their practice because of the lack of availability of BCG? Yeah. So maybe not 100%, but it seems like a large number, a large percentage of you. And this really started in the late teens, 2016, 2017. Here's a statement that the guideline panel was asked to write in 2019 in response to the BCG shortage, and sort of a discussion regarding the Merck manufacturing response to it and what they were trying to do. At that time, there were 2 major U.S. producers of BCG. This is something you may be aware of, Merck and Sanofi Aventis. Sanofi Aventis production plant was actually in Canada at the time for their U.S. distribution. They had some environmental issues in the plant, and the company made a decision to not refurbish and reintroduce the production. So they pulled out of the global BCG producing market and left Merck alone. And I would say maybe anecdotally that a lot of people in our community, patients and doctors, have sort of maybe vilified Merck for not making enough BCG fast enough because they're the only remaining producer in the U.S. market. So how come you can't make BCG more quickly? How come you can't ramp up production? Why is this a problem? When in fact, if anything, this is the only company that actually is willing to stay in this market for lots of reasons, but mainly it's a biologic drug. It's very old. It has a price limitation, and it doesn't have a big margin, just to say it, very transparently. So in some ways, without Merck, we wouldn't have BCG, basically. It would just be gone. So the BCG shortage is only a shortage because of Merck. And here's, some of their statements that they've released over time, a commitment to increase production and dramatically increase as much as they can from the existing plant, which is in Durham, North Carolina. In addition, this was in 2020, a commitment to actually create a new production facility, which would take approximately 5 to 6 years that would allow them to increase production even more. That, to my knowledge, at this moment, that plant's not online yet, but it should be coming probably within a year or two if they've stayed on that schedule. I think one of the things that we don't necessarily point out here is just tying in Seema's comments regarding maintenance. So maintenance was first really described as an effective intervention with BCG in the early 2000s, but didn't have a huge uptake, mostly because many maintenance trials in the past had been negative, mostly based on a monthly maintenance schedule prior to the initial SWOG trial and subsequently the EORTC trial. And the maintenance utilization uptake took some time. As that ramped up, you have to realize that an individual patient, let's say, who's diagnosed with CIS, actually goes from requiring 6 doses of BCG to requiring 27 doses of BCG over their course of treatment. So there's 21 treatments of full-strength BCG in a 3-year maintenance program, and nobody sent a memo to Sanofi and Merck and said, we are going to increase utilization of BCG, even with a stable population of patients, which, that the bladder cancer population in the world is always growing slowly. So we ramped up our consumption while they were ramping down their production by taking one of the main suppliers out of the market. I don't think that gets discussed quite enough. That's what's really left us in this position now. So this is roughly the numbers from Dr. Al-Hussein, who was at Vanderbilt at the time. About 870,000 vials of Tice BCG can be produced annually, and that's an increase in production to kind of the max capacity of that single production facility, and a commitment, again, from Merck that they would do everything they can to increase BCG. This has been covered a lot in the popular media. It's kind of quieted down lately. And I think that, some of the frustration about where BCG comes from and how you can get it, it's not directly coming to you from Merck. It's coming through wholesale distributors that have formulas as to how they allot it. May or may not agree with how those formulas work, but high consumption centers oftentimes use up their allotment of BCG very quickly and don't necessarily have allotments that are adjusted to the demand for that center. So we at Columbia, or Chris and I practice, have had significant and variable problems acquiring BCG over the past 8 years, I would say, ranging up to just absolute absence of the ability to use it over time. So here's what the AUA has said in terms of what we should do. First, and we've touched on this already through the talk, BCG should not be used for patients with low-risk disease. That's pretty self-evident. Even without a shortage, people with papillary low-grade tumors less than 3 centimeters don't warrant BCG. They don't need it. Don't waste it on them, please. In the next level of intermediate risk disease, intravesical chemotherapy should be stressed as a first-line option. If you're going to use any adjuvant therapy, don't start with BCG, even though it's on the guidelines and says it's an option. Try to, if you can, use intravesical chemotherapy, the most common ones being single-agent mitomycin, gemcitabine, epirubicin, docetaxel, or potentially even a combination of one of those two. If BCG is administered in this group of patients with intermediate risk disease, consider intravesical chemotherapy first, and only BCG if you absolutely have to in the setting of a BCG shortage, so second line in intermediate risk patients. Oftentimes, we will adopt second-line gem-dosi or gemcitabine docetaxel combination for intermediate risk. There's a fair amount of new agents coming out in this area as well, but try not to use up your supply of BCG for these patients. All right, so what about high-risk non-muscle invasive? Here's where things get a little conflicting because we have guideline statements that tell you when and how much BCG to use in people with high-risk non-muscle invasive bladder cancer, but in the shortage era, we've sort of modified some of those recommendations, making them maybe conflict with the actual guidelines. So for high-grade T1 and CIS patients, receiving induction therapy should be prioritized, and that means prioritized over maintenance. So if you have a population of patients and you want to get the most efficacy out of a limited supply of the drug, stick to induction full strength. Really try to avoid dilution to 1/3 or 1/2 strength in induction if at all possible. If not available at all, these patients and other high-risk patients could receive 1/3 or 1/2 strength. And here's one of the first conflict statements, because we just saw the randomized trial that looked at high-risk patients receiving less than full-strength BCG for 1 or 3 years, and it's inferior. So here's a statement that says you can do this knowing that the evidence in this field indicates that that is going to be less effective than full-strength BCG. The implication there is that 1/3 strength is better than nothing. So if you have no access to BCG and you have to ration it, it's probably better to use 1/3 strength than no BCG. If supplies exist to get maintenance therapy for your patients, try to dilute it whenever possible. And of course, if that's the case, don't dilute it and discard the rest of the BCG, leading to the simultaneous use of 1 vial of BCG to treat up to 3 patients on the same day in the same clinic. A logistical challenge if you've ever tried to do it, but that's better than using 1/3 strength and throwing out the other 2/3. That doesn't make any sense. Don't do maintenance therapy if possible in BCG naive patients with high-risk disease if you have to prioritize for induction for other patients. And again, direct conflict to all the evidence that we have that says maintenance is better than induction alone, but in the time of a shortage, you could potentially switch to that. All right, what if BCG is not available at all? It's not even a matter of diluting it or decreasing the strength. A preferable alternative is potentially monthly either induction mitomycin and monthly maintenance up to 1 year, or gemcitabine. Epirubicin is on the list, although it's not really used in the United States. Docetaxel, valrubicin, or sequential gemcitabine and docetaxel. I'm going to go on a limb here and say that the default regimen in this situation in the United States, and we'll talk about this during the BCG unresponsive area, is rapidly becoming gemcitabine docetaxel, despite the fact that it's not FDA approved for any indication in bladder cancer. I think urologists have become very comfortable with it. I think right now a default option that's the most commonly used for BCG unavailable situations has become docetaxel gemcitabine combination. And then here's one that's kind of a little bit controversial. In patients with high-risk features, high-grade T1, potential other factors such as variant histology, lymphovascular invasion, prostatic urethral involvement. These are the highest risk, and in the EAU guidelines, they're actually in a separate category for very high risk. These are patients that are least likely to have a durable response to BCG. If you want to consider moving cystectomy up, which is on the recommendation list, and actually saying in this situation you have multifocal high-grade T1 with lymphovascular invasion, your likelihood of being cured by BCG is probably in the high single digits, and we don't have any. So why don't we start talking about cystectomy? It's difficult because a patient might say, well, it's an option. I'd like to have an option to save my bladder. You're telling me you just don't have the drug to give me, so you want to have a cystectomy instead. But selectively choosing the patients that are at the lowest likelihood of responding, and again, not quote unquote wasting a limited supply of BCG on someone who has a very low likelihood of responding. I mentioned this already, that if you're going to reduce the dose of BCG, try the best you can to use at least one of the other aspects of the dose. If it's a third strength, try to treat at least 2 patients, and if possible, 3 patients on the same day. And consider clinical trials. Chris mentioned the explosion in urinary biomarkers. I would say in BCG alternatives as well as BCG unresponsive alternatives, which we'll hear about later, there's been a massive increase of interest. In the primary setting, some of that interest is being drawn by the absolute shortage of BCG. And as many of you may know, there's a randomized clinical trial referred to as the BRIDGE trial that is now evaluating first-line gemcitabine docetaxel versus BCG. That'll probably be the first ever prospective trial indicating gemcitabine and docetaxel as an effective alternative. If we flash forward, that trial's not over yet, but I think most of the retrospective evidence would suggest it's likely to be non-inferior to BCG in this setting. I have no evidence to support that statement right now. And by the time we get to the new factory making more BCG or recombinant BCG, we may have already figured this problem out and put some alternatives in the first line area, making our dependency on this difficult to make biologic treatment lower. I think that'll be a good thing in general for society. I'm going to stop there and turn it over to my colleague, Dr. Christopher Anderson, to talk a little bit about BCG unresponsive, which interestingly requires you to have BCG to create. So if you ran out, it's going to be hard to make this entity. Thanks.
All right, great. That was a great overview. Thanks very much, Jim. So let's talk about BCG unresponsive disease. This is a huge space. There's been a lot of products at this very meeting, trials at this meeting that you may have seen. And I think it's worth kind of seeing where are we now and where are we headed. So let's start with the case. 61-year-old patient who has high-risk T1 disease, large multifocal high-grade T1 with CIS. You resect it, but you say, looks pretty bad, you should probably consider cystectomy, does not want that, gets BCG induction, 1 course of maintenance, and then recurs with CIS at 6 months. Negative imaging, negative prostatic urethra. So let's go over a few definitions. I think this was one that was presented earlier, but I think it's worth revisiting here. What is BCG unresponsive non-muscle invasive bladder cancer? All of the following except recurrent or persistent T1 after induction BCG, recurrent TA-T1 within 6 months of adequate BCG, recurrent CIS within 12 months of adequate BCG, or recurrent low-grade TA after adequate BCG. Answer 1, 2, and 3 are all part of the definition of BCG unresponsive disease. And this is really important to understand. to determine which, if any, of these treatments might be, or which patients may be eligible for these treatments, and when to not give additional BCG. And the guidelines really do talk about this very specifically. There's 3 points here in the guidelines that I think are worth emphasizing. One is that we should not be giving additional BCG to patients who have high-grade recurrences within 6 months of adequate BCG. We should offer cystectomy to a patient with recurrent high-grade disease within 12 months of adequate BCG. And for the patients who don't want a cystectomy within 12, who need it within 12 months of BCG, who don't want a cystectomy, you can either offer a clinical trial, you can offer some sort of alternative intravesical therapy, or systemic immunotherapy with pembrolizumab, and Jim's going to talk to us about that a little bit later. All right, another definition, adequate BCG. What is adequate BCG? Defined as, what is the right answer? A single 6-week induction course, 6 week plus 1 year of maintenance, 6 weeks plus 3 years of maintenance, or 5 of 6 induction doses plus either 2 of 3 of a maintenance dose or 2 of 3 of repeat induction. And the answer is 4. So this is also really important to understand is when has a patient been given sufficient BCG to be deemed BCG unresponsive? And if they haven't gotten these, enough BCG, then potentially it's still worth re-challenging with BCG. And I think that's well represented on this figure here, kind of the the different buckets that get you into the BCG unresponsive group. So let's go back to our patient. He had bad disease to begin with. He recurred within 6 months of adequate BCG. He definitely has BCG unresponsive disease. And you tell him you should have a radical cystectomy. That's what our guidelines say. That's what I think that would be best for your long-term health. And he says, no thanks. What else you got, doc? So you have to talk to him about this. And I think fortunately we're in a better position now than we were a couple of years ago when there really wasn't a whole lot commercially available. We have a whole bunch of new agents right now that we can consider for our patient. And why is this an important conversation to have? Well, this is real cancer. Patients with BCG unresponsive disease have, historically speaking, have a high rate of progression to invasive disease, have a significant risk of mortality from bladder cancer. And we know that if you wait till a patient progresses to invasive disease, the cure rate is substantially lower than if you treat that patient when they have clinically non-muscle invasive disease. So, this is a real condition that really requires our attention and escalation of treatment. The hard part is that for patients who don't want cystectomy, like our patient here, there really isn't a standard of care. Our guidelines say that there really is no optimal management. There's a lot of options, and there's a lot of right answers too. You can see here, this is just a figure that represents the numerous drug targets that are either for currently approved medications or medications that are being studied right now. You could currently choose a couple of different drugs that are represented on this figure, and we're going to have several more to choose from in the near future, and all of them may be right answers at this point. And I think importantly to tell our patient who does not want a cystectomy that, perhaps we're getting a little bit better for salvaging patients with intravesical therapy, maybe with better selection criteria, arguably better intravesical agents that, we actually can decrease the risk of cancer-specific mortality is probably a little bit lower now than it used to be. Maybe you can help 2/3 of patients avoid a radical cystectomy with intravesical salvage, and that's kind of as good as we've gotten up to this point. But we've got a couple of new options now. Here's the landscape for what you might choose from for your patient with BCG unresponsive disease who does not want a radical cystectomy. I think an important benchmark is to understand what does the FDA kind of recommend as far as efficacy for intravesical agents for BCG, particularly for BCG unresponsive disease. This is a disease state that you cannot resect. We've talked about this before. You can't really do a thorough TUR of patients who have large multifocal carcinoma in situ, and so it requires some sort of a topical or systemic treatment to get rid of it. And so the FDA and the AUA kind of agreed that complete response rate for an intravesical agent is really the primary endpoint. The duration of complete response is also very important, so that's why that's really emphasized in a lot of the trials that have been written and that we'll review. And that what is a clinically meaningful benefit for these drugs? Well, about 30% complete response rate at 18 to 24 months. So that's kind of where they've set the bar. And let's see kind of how are we meeting it or exceeding it, or how are we standing at this point? Well, for years, valrubicin was the only FDA-approved treatment for BCG-unresponsive disease. Up until 2022, it was the only treatment approved for over a decade. And it's really not very good. As a monotherapy, it's given intravesically once a week for 6 weeks. 20% 3-month complete response rate. Almost all of those patients eventually recurred. About half of the patients required a cystectomy in that study. So it's very expensive. We pretty much never use this as monotherapy, and I think very few people do. But in 2022, we were fortunate to get something new, which was the Adstiladrin. Many of you have seen Adstiladrin, or otherwise known as nanofargine. This is an intravesical adenovirus, and it delivers a gene, an interferon gene, into urothelial cancer cells urothelial cells, and turns the bladder into an interferon machine. And many of you are aware that intravesical interferon has actually been shown to have effect as a good immunotherapy for non-muscle invasive bladder cancer. So it's basically making interferon in a person's bladder. It's given as a single dose at time 0, and then for patients who respond, additional single doses at 3, 6, and 9 months. In the phase 3 trial for BCG-unresponsive patients, there's a 53% complete response rate at 3 months, and about half of those patients had a durable complete response rate, so that by 12 months, about a quarter of the patients were disease-free. Low rate of progression, about 5%, but a third of patients ultimately required cystectomy. A lot of local toxicity with this, kind of as one would expect. I would say anecdotally, we've observed that maybe it's even a little bit more difficult for patients to hold this drug in their bladder, so we do a lot of pre-treatment. We've been using, in addition to anticholinergics, things like rectal Valium or vaginal Valium suppositories, which I think has helped a bit. But this is approved, so this is on the shelf. Costs about $60,000 per dose of this drug, and this is something that we could offer to our patient. What else can we offer? Well, Anktiva. This is another FDA-approved drug. This was approved last year. This is a different mechanism. It's also an immunotherapy. It works as an IL-15 superagonist, and the principle here is kind of a 2-hit immune hypothesis, where if you stimulate IL-15 in addition to another immune stimulus, it's additive, and it perhaps works even better. So this is given with BCG. You literally mix this drug together with BCG, give it into the bladder. From a study published 2 years ago, the response rate at any time was 71%. Now, this is different than the nanofargine study design. This allowed for repeat induction therapy. So for patients who still had disease at 3 months, many of them got reinduced, and about half of the people who got reinduced actually became complete responders. So that's probably one reason why the number is a little bit higher. But ultimately, about half of the complete responders were disease-free at a year. So for many patients, this is a durable complete response. It is approved. Again, expensive drug, anywhere from $30,000 to $40,000 per dose, with 6 doses, and you see the data there. So what else do we have? Jim talked a little bit about Gemdosi. So this has kind of been the default treatment for years, particularly before we had anything that was FDA approved that was effective. This is not FDA approved. All the data in this space is retrospective or observational. This is kind of how many people give Gemdosi. You usually start with gemcitabine, 1 gram and 50 cc's for an hour, drain it out, give 37.5 milligrams of docetaxel for an hour, drain it out once a week for 6 weeks. So it's a little bit longer of a clinic visit for those patients. Some of the observational data, though, suggests that the 2-year high-grade recurrence-free survival is reasonably good. Maybe at least 50% of these patients were without evidence of high-grade recurrence. Handful of patients still required cystectomy, anywhere from 10 to 15% of patients, and probably arguably giving monthly maintenance was beneficial in several of these studies. And so now that this is our updated NCCN guidelines as of last summer, and you can see at the very bottom here, I'm sorry. Well, at the very bottom, for BCG-unresponsive disease, even though cystectomy is still listed as preferred, that does specifically list intravesical chemotherapy, Adstiladrin, and Activa as options, as well as pembrolizumab that we'll hear more about in a minute. All right, so I'm going to just finish with a couple of slides on kind of what's coming next, and I think there's a lot of interest in these products. Worthwhile knowing kind of what's on the way. So the TAR-200, otherwise known as the pretzel, this is a device that is implanted in the bladder, and it releases gemcitabine, slowly releases gemcitabine. So you kind of have a constant dose of intravesical gemcitabine. You give it once a week, or sorry, every 3 weeks for, 4 months, and then every 12 weeks after that. For the Sunrise trial, which was a BCG unresponsive trial, the overall complete response rate was over 80%, and the 12-month complete response rate was 57%. So this has FDA breakthrough designation. This will probably be on the shelves maybe this summer at the earliest, but probably this year, so expect this coming. Credo, this is another a very promising agent. It's another oncolytic virus, and it targets RB-deficient cells, which bladder cancer is often deficient in RB, and it directly leads to cell death and an immune response. They found a 74.5% complete response rate at any time, and the durable complete response rate was over 60%. So, we're kind of seems to be these agents are continuing to be effective and perhaps even getting better. This is the Engene product, which is a non-viral plasmid, also given intravesically, leads to an immune response, over 70% complete response rate. This is from an early phase 2 trial, but this is still being studied. And then shameless pitch here. This is a Columbia kind of homemade trial that we've been working on for several years, and the phase 2 data was presented last year at ESMO. This is a triple drug therapy, cabazitaxel, which is similar to docetaxel, gemcitabine, and cisplatin, intravesical cisplatin, and we found an over 80% complete response rate, many of which were durable. So we're excited about this. But I'll end by saying that many of these BCG-unresponsive cancers can be salvaged. I think selecting the right patient for salvage therapy is difficult to do. I may open this up to the panel, and how do we select patients for these drugs, and which drug, if you were forced to choose tomorrow for all these various FDA-approved options, which ones do we choose and why?
So I have a couple thoughts on that, but primarily also, if you guys have noticed in all these trials, there's this, it's the overall response, which has no clinical relevance in terms of talking to patients, right? So that's response at any time. These numbers across the studies are like 75, 80, and you're like, well, I don't even really know what to do with that. I lead one of these trials, and sometimes I'm up there and I'm like, I don't even know what I'm talking about right now, because it's how do you take that and show it to a patient, right? So I find it really hard because patients want to know what is the chance this drug will be working in a year and in 2 years. So there has been a little bit of change in some of the way the numbers are presented in the conversation. So really, as you're looking through, those numbers will kind of distract you, but what you're looking at is the landmark complete response rates at 1 year and at 24 months, right? Those are around 50 or 60%, and then like 30 to 40% for a lot of these agents. So the durability is getting better than what we had before, but sometimes I find it really confusing when I see the anytime response because I don't really know what to do with it. So pay attention, and it's not going to be the biggest graph on the screen, right? It's going to be the one next to it that actually has what's the response at 12 months and what's the response at 24. And so I've been trying to pay attention to that part. And then you try to organize in your brain what you think may end up working for a patient. A lot of it right now is dependent upon insurance coverage, right? So Medicare will cover these drugs at 80%, but 80% of 60,000, you still have to pay a lot for that dose. So patients, that's what their out-of-pocket cost would be unless they had a supplement. But I would say not every patient has Medicare. Who knows what Medicare is going to cover in the next year or so, as there might be changes coming, right? And so I think many patients cannot afford any of those drugs. So that is one kind of factor of how do you choose. And so it ends up defaulting to either clinical trial, which is still relevant and reasonable despite all these other things that we may have coming, or relying on chemotherapy in my practice. Now, if somebody has like this awesome insurance and they can get whatever, right, then it's really looking at, I'm really looking at what are their local symptoms, right? What's their overall comorbidity? And that may help me think about, well, I'm not really sure they can tolerate another 27 treatments with BCG and IL-15, and I may not even have BCG to do that with, but I might. So I look at that. For natafarigine, it's once every 3 months. That's actually pretty reasonable. So someone whose bladder is sort of beat up, that may not be a bad option. Although I do say they all get really a lot of anxiety because they're like, I have $60,000 in my bladder. I cannot empty this in like 10 minutes. So they all get Ativan. Everybody gets Ativan, all kinds of Ativan, apparently.
Right.
And that is very helpful. And then for systemic pembrolizumab, that is a harder sell because of the probably real AE toxicities at this time. So I think it'll be really interesting with the next set of treatments. And I think it'll continue to push the field forward. But it's pretty hard to, even in my opinion, to kind of parse through the data sometimes. And then kind of help patients make the next best decision. So I fall back a lot to intravesical chemo.
I just want to agree 100% with what Seema said. And in terms of disease factors, so, I look at whether they have papillary or CIS, or if it's mostly recurrent CIS. In the Anktiva study, a lot of those patients were CIS patients, and that seemed to be what drove the high CR rates. So if I have a patient who's got a lot of CIS and has been going through this, and this is purely anecdotal, I would probably lean towards using, Anktiva or Adstiladrin. Otherwise, I'm using Gemdosi for a lot of these papillary diseases.
Great. All right. Thanks. I'll turn it over to Jim.
Thanks. Yeah, maybe I'll link. This next topic is systemic therapy for BCG unresponsive, but maybe follow on to some of the comments Seema made. Some great things happened with that FDA kind of bar setting in 2018 is that they put some definitions on the disease state, some expectations for biotech and pharma companies as to what people want to see in an effective treatment for BCG unresponsive disease. But it spawned sort of a strange, I would say, evolution that really involved endpoints and outcome measures. And when you look at these trials, and Seema touched on this, you have to be really careful, one, on the inclusion criteria. So some of them are sticking to the FDA definition, including CIS in a cohort, and then reporting on a cohort that doesn't have CIS, which actually was not really part of the FDA inclusion criteria. And that's mostly because people who don't have CIS can be cured by surgery. And again, to my point earlier, a lot of those people have had inadequate surgery and adequate BCG. So the new drug may or may not be such a big factor there. CIS, as we know, is harder to cure with surgery, probably not impossible to cure with surgery, but harder. So the drug's kind of impact can be better assessed. And that's one of the reasons why that's part of the FDA criteria. The other thing that's going to come up in this part of the presentation is that some fuzzy and funny math things started happening in some of these presentations, one of which is this response at any time that Seema alluded to. So normally when a cancer study, you give someone with cancer a drug, you determine what happens. In these trials, some do and some don't allow the drug to be given again if it didn't work. So for instance, in the Anktiva trial, if you didn't respond, you just got it again. And if it worked the second time, which it did in a lot of patients, you were included in the success. And so that's like saying BCG, we give it to you. If it doesn't work, we give it to you again. And now you are cured with BCG. Now, the patient who gets cured is great, But that didn't happen in a lot of other studies. Like, for instance, in the pembrolizumab trial, that wasn't allowed. So response at any time changes the game. And then the other factor, which we're going to talk about here, is sort of assessing response in responders, which is like this weird not intention to treat phenomenon, which is now happening in pretty much every trial. All right, we're starting off with another case. 69-year-old female presents with gross hematuria, diagnosed with CIS. All visible areas of CIS are resected or fulgurated. We've touched on this a little bit. I am a firm believer that there's therapeutic efficacy for surgery in people with high volume CIS. I think our tendency is to see a patient who lights up with blue light and biopsy them and say, oh, I got CIS, I got what I need, I'm out of here, and I'm going to give them BCG. And it just doesn't make any sense when that area is either resectable or ablatable with cystoscopy technology. Try to do that whenever possible. She gets BCG induction followed by maintenance for 3 months and 6 months. 9 months later, she has a suspicious area, has another biopsy/TUR, and it shows CIS again. So it gets a second round of induction BCG as per the guidelines. That's one of the main options. And given high risk, her next cystoscopy is done in the OR, and she has a biopsy. It shows multifocal CIS immediately after the second induction. So she fits the criteria now for BCG unresponsive. She does not want a cystectomy. She does not want to follow the guidelines there. So one of the guideline statements says here, at this point, a patient should not be receiving additional BCG who has become either intolerant or unresponsive to BCG within 6 months or 2 induction courses of BCG, as Chris outlined in the definition. So here's another example, particularly in a time of shortage. Don't continue to treat someone who's unresponsive with BCG. It's kind of self-evident, but I've seen over many years of referral practice, I've seen people with 3, 4, 5, 6 consecutive induction courses with minimal to no response. That's not only a waste of BCG, it's a waste of time for the patient and potential risk for progression. So don't do that. And a patient with persistent or recurrent non-muscle invasive disease within 10 months of completion of adequate BCG, as defined earlier, who is unwilling or unfit for cystectomy, a clinician may recommend entry into a clinical trial or an alternative therapy, such as the ones that Chris just outlined, nadofaragene, or alternative intravesical chemotherapies, including gemcitabine and docetaxel. Now, gemdosi made it into the guidelines despite not having an FDA approval. At the time of this guideline being written, nadofaragene was just FDA approved and Anktiva was not, and that's why it's not in there. And the data on gemcitabine is probably a little bit worthy of caution because it's retrospective. Most of the definitions that we use today for BCG unresponsive were not either created or adhered to in the accumulation of many of those retrospective studies. So if you really drill down on who got gemdosi and the various numbers of collaborative and single center retrospective studies, it's a little bit more heterogeneous population, lower percentage of CIS, some intermediate risk patients, some people who got 1 induction course of BCG. So in a prospective trial, it probably wouldn't do quite as well as it has been doing in some of these retrospective series, but I'm still a big believer in it and moderately biased, which I'll address later. I didn't describe that earlier. All right, what about pembrolizumab? So I think everybody here is familiar with this drug. It's basically revolutionized the treatment of cancer as we know it in our lifetimes. It's an immunotherapy. It's a PD-1 inhibitor and is currently a standard in multiple different aspects of both metastatic, locally advanced, and even muscle-invasive bladder cancer, either alone or in combination with other drugs such as EV. So this is the biggest trial. This actually was the first study approved by the FDA for non-muscle invasive bladder cancer after valrubicin. So this was approved prior to Adstiladrin being approved. So after that roughly 20-year hiatus of no approvals, this one hit the market before any intravesical therapies were approved. And this was an FDA, registration trial, so it adhered very carefully to the inclusion criteria of patients with actual documented BCG unresponsiveness and CIS. And they had incidence 46% of patients after receiving 3 weekly doses, every 3-week dose of intravenous pembrolizumab for up to 2 years if they were responders, had a 46% NED rate at 12 months in the responders. So the way this trial was initially presented was an initial complete response rate and then a reanalysis of that cohort at 1 year, as opposed to an actual reanalysis of the entire cohort that was treated. If you include the total roughly 100 patients that were in the trial and the ones who didn't respond at the initial assessment, the actual 1 year response rate was just under 20%. And this, I think, confused a lot of people because 46% at 1 year at that point would have been revolutionarily, improvement over every other agent available. But in fact, it's less than half of that if you actually include all the patients that were in the study. And to Seema's point earlier, I mean, patients are, asking pretty simple questions like, if you put me on this, will you cure me of my cancer? We know everything we do in non-muscle invasive bladder cancer is a time-dependent outcome. So I always answer that by saying, cure you when? Cure you in 3 months? We have a reasonably high chance of that. Cure you in 9 months, 12 months, 27 months, 59 months? And if the person's 65 years old, they say, no, cure me when I die of something else. That's what I want to know. And that's it. That's almost never an answer we can give them because we don't know how long they're going to live. But this drug at 1 year, roughly 1 in 5 people will not have cancer if they get it. Systemic side effects in the treatment were not trivial, and grade 3 and 4 side effects for immunotherapy. If you've seen people with metastatic or muscle invasive bladder cancer, these can be relatively, I would say, unusual, highly unpredictable, and oftentimes catastrophic and devastating, including things like pancreatitis, pneumonitis, hepatitis, hypophysitis, renal failure. So grade 3, 4 toxicities, 13%. I think it was last year, maybe the year before at the SUO, Max Cates gave a great presentation regarding a urologist's tolerability of a complete response rate of 19% and a 13% chance of basically hospitalizing their patient with stage 1 cancer, because most grade 3 or 4 toxicities involve some type of intense therapy. And that's a tough ratio when you sit down with a patient and say, hey, there's a 1 in 5 chance I could give you a disease-free survival at 1 year, and there's a 13% chance during that year that I'm going to really mess up some other organ in your body, and some of it may not be reversible, including pancreatitis, resulting in type 1 diabetes, which is permanent. So tough one. I don't know the statistics on utilization for this drug currently. We use it very rarely in people with high volume of sort of, I'll call it perivesical disease, like inclusive of prostatic urethra or refusing cystectomy. Look at it as a systemic therapy, maybe a risk of ureteral CIS or something that they're just absolutely refusing surgery. It gives you the advantage of at least treating their entire body. Maybe you're worried about risk of progression and they still don't want to have anything done and they're risk tolerant. I'd say this is a population, most of whom have had a lot of intravesical therapies, and they're moving into a new space. They have to be aware of what that space is, different treatment, another physician, new center, and new risk profile. So it did lead to FDA approval. I think, that was at a time when we hadn't had approval in 20 years, and it is currently approved for BCG-unresponsive high-risk non-muscle invasive bladder cancer with carcinoma in situ, with or without papillary tumors. And that's not oftentimes stressed when people are talking about it. Technically, by the FDA criteria, the patient has to have CIS to go through this. Now, having built up the role of systemic therapy, I'm going to turn it over to my colleague who's going to convince you that cystectomy is the best systemic therapy for this condition. Chad.
All right, so as we wind down, I'm going to quickly run through a case about radical cystectomy in high-risk disease. So this is a case, it's a 26-year-old female with microhematuria. Office cysto reveals a very large bladder tumor. It's filling approximately 70% of the bladder. CT scan, fortunately, does not show any metastatic disease. I'll show you the CT scan right here, where you can see clearly very high burden disease in a very, very young female patient. So, obviously when she saw that and we discussed the options, she was devastated. But she underwent TURBT. It was a very difficult one. Pathology came back as invasive to the lamina propria, so high-grade T1 muscularis propria was present and not involved, but it was filling the entire bladder. I mean, I can't even do it justice by describing it, but eventually we had to stop because the case was going 3 hours and obviously a very high risk of perforation, bleeding, complications. And the last thing you'd want to do for a 26-year-old is perforate their bladder and then seed the peritoneal cavity. So at that point, we stopped, we resected as much as we could, and then discussed the options. Now, this case illustrates, where we are in the guidelines as far as the role of cystectomy. So we're not going to use a cystectomy as per guidelines 27 in a case of low or intermediate risk disease. That's not the preferred. You need to exhaust all your bladder sparing modalities. However, in a case like this one, a high risk patient who is fit for surgery, persistent high grade T1 or tumors associated with CIS, LVI, variant histologies, again, these bad actors that I referred to in the risk stratification in the beginning of the course, those patients you should consider offering a radical cystectomy. And that's a moderate recommendation. The evidence is mostly retrospective, but that's a stance on a high-risk patient. And then, of course, as my colleagues here mentioned, in the BCG unresponsive space, so patients who have a persistent or recurrent disease after BCG offer radical cystectomy. So everybody was saying patients don't want cystectomy. This patient was like, yes, cystectomy right away. Didn't even want to try anything else, which I agreed with, and I think we all can agree probably was a good call. But this brings up some questions. So we take somebody for an early cystectomy, standard operation as with muscle invasive, but what about things like the lymphadenectomy? Do you do one? Do you do an extensive one? And really, we just have some retrospective data here, but essentially, this is data, a multi-center study, retrospective, looking at 355 patients, and most of them were high-grade T1. A lot of them had prior BCG, and all the patients underwent standard lymphadenectomy. And what I want to illustrate with this study is that you can see here 25% were upstaged in these high-risk patients, and 8% were upstaged by N status, nodal status. So positive nodes in these high-risk non-muscle invasive cases, and huge rates of upstaging. And what that led to, and this is the other take-home part from this, is if you're upstage, if you have high-risk disease, you're upstage to node positive, obviously you do worse. So, the bottom is the upstage group, the top is those who were not upstaged. And then just additional data from here in the US at MD Anderson, their series, same thing. So, in high risk, very high risk, non-muscle invasive, 23% upstage and 8% nodal upstaging. Those who got a delayed cystectomy, so they tried BCG, and instead of doing it at a timely interval, they still had high rates of upstaging and node positive. So here, the role of lymphadenectomy in someone with non-muscle invasive is, number one, do a good lymphadenectomy standard. So you follow the same template for muscle invasive. And now we have level 1 evidence that we, I guess, don't need to do extended lymphadenectomies. It gives you accurate staging and prognosis. It can change your post-op management. Obviously, we're going to, if somebody's node positive, give additional therapy. And again, we use the standard template. So in this case, she actually did have positive nodes. And then she was treated with chemotherapy afterwards. And this is she had a robotic intracorporeal neobladder, and she's doing great 5 years later. All right, thank you.
All right, a lot to consider. We're going to finish up just with a couple of slides on intermediate risk non-muscle invasive bladder cancer. I also want to highlight that several of the cases today had female patients, and we all know that females with bladder cancer experience worse outcomes, tend to have more advanced disease. And there's a number of different theories and kind of working ideas for how and why that happens, but we need to just make sure that we're taking great care of those patients, and our index of suspicion in patients who have hematuria and who are females is high, so that we're not missing the window for cure in these patients. So this case also is a 72-year-old female. She has asymptomatic microscopic hematuria, which it doesn't say there, 15 red blood cells per high power field. She does have a smoking history. When you guys all know that this year, the updated asymptomatic microscopic hematuria guidelines did note that a woman cannot be placed in the high risk category based on age alone. So that was a change to the guideline. Her cystoscopy showed 3 small tumors, each less than 1 centimeter. Her complete TURBT showed low-grade TA. So she is intermediate risk according to the AUA risk stratification system. And I just want to highlight that there are different risk stratifications out there. An intermediate risk is the one that tends to be the most kind of varied. It is kind of a catch-all, and that is problematic, I think, when it comes to counseling our patients and figuring out what best practices are, because we don't really necessarily know the risk when it's such a heterogeneous group. You're mixing sizes, you're mixing high grade and low grade, and it can be really challenging. Just to kind of highlight here, the EAU guidelines are a little bit different. You see they have a very high risk category, and low grade T1 is characterized as low risk, a little bit different than what we have in the AUA guidelines. But basically, it's this catch-all. No CIS who are not included in either the low, high, or very high risk groups. There is another organization, the IBCG, International Bladder Cancer Group, and they've put forth this algorithm with risk scores to define intermediate risk disease, which does have an impact on predicting probability of recurrence and progression for patients. They have some different treatment options. But to kind of cut to the chase, what do you do with these patients? Do you offer them intravesical therapy? When and how much? And how do you survey them? I think that I know that there's huge variability in practice in how we manage these patients. One kind of point I put on this slide here is, what about focal high grade? Focal high grade can be a really challenging and frustrating diagnosis to receive. It means basically less than 5% of the specimen the pathologist saw had high grade features. What do you do with that? We tend to treat patients as high grade in that setting, but definitely challenging. So when you look at guidelines, currently what is recommended is either intravesical therapy or surveillance. And the intravesical therapy, as we heard about before, can be BCG, but we're prioritizing actually the high risk patients there. So oftentimes it's intravesical chemotherapy. I also want to make the point that intermediate risk, especially if you're a low grade intermediate risk patient, that's more of a chronic disease. If you have a low grade bladder cancer that puts you in the intermediate risk category, that is generally not something that is going to shorten your life, that is going to result in major, quality of life issues outside of the cystoscopies and the treatments that we put in your bladder. There's some data for surveying small tumors in patients. And so I think we need to be thoughtful about the patient in front of us and the risk of disease. That said, this space has seen a ton of development. It's almost like, the new BCG unresponsive space. And so I just want to highlight a couple of slides in the next 30 seconds, and then we'll offer you guys a chance for any questions from us or for us. So what about chemoablation? So that is leaving residual tumor behind, not doing a TURBT in someone has low-grade disease. If we can spare the patient the risk of an anesthetic and treat them that way, that's kind of an exciting option. So the Envision trial is a primary chemoablation with this reverse thermal gel mitomycin. We see that patients had a pretty good complete response at that initial 3-month mark, but as we've discussed, what does that really mean? We want to know kind of the long-term and the durability, and we do see that, at least in the initial data, patients have a relatively promising long-term result, lasting result there. We've heard a ton about cretostimogene this meeting for patients in the high-risk BCG unresponsive space, but this is actually being evaluated again in intermediate risk. This is a conditionally replicating adenovirus that lyses RB altered bladder cancer cells. Another potential option for intermediate risk patients. We've heard about nadofaragene for our high-risk patients. Well, what about intermediate risk patients? This is a non-replicating recombinant adenovirus, and this is delivering interferon alpha into urothelial cells, and this is kind of an enhanced viral transduction showing some promise. Again, as I'm telling you these things, I want you to be thinking about the potential cost that we highlighted earlier as well with some of these agents. Kind of interesting, but we know for patients with advanced urothelial carcinoma and metastatic disease, erdafitinib is an option, and this has been studied in non-muscle invasive bladder cancer, including intermediate risk. This initial Thor trial included a small number of patients with intermediate risk, and these patients had a response, but they actually, with oral erdafitinib, had really significant side effects. But what about putting it directly into the bladder? So this TAR-210 looked at erdafitinib pretzel essentially in the bladder in this early study, and one of the cohorts, cohort 3, saw some promise. This was recurrent low-grade Ta/T1 disease, and we see a durable response, importantly, in those who have FGFR3 alterations, or sorry, just FGFR alterations. There can be a number of different alterations in FGFR. And so now we have the Moonrise trial, which is ongoing, looking at TAR-210 versus investigators' choice of intravesical chemotherapy for intermediate risk patients. Earlier phase studies looking at TAR-200 for intermediate risk, as well as the combination of intravesical gemcitabine and N-803 for intermediate risk patients. So all of this is really exciting. But if you're spending thousands and thousands of dollars for something that may not impact the outcome for your patients, I think there's a lot to be discussed there. And I mean more like survival outcomes. You can see, as you all know here in this slide, that bladder cancer is one of the most expensive cancers to manage. And so I think while these developments are exciting and I want to continue to see them and these trials are important, how we deploy them is a really, really important conversation. So I'm going to just for one second shift gears for a second, because I think I saw a question in the chat about what do you do, Seema? I'm going to ask this question to you, for patients who had an initial resection with blue light. Do you still need to do a repeat resection on a patient, as the guidelines say, if their first resection was with cis-view TURBT?
Yeah, I think with enhanced cystoscopy, the use or non-use of the technology does not kind of mitigate the reason for the repeat resection, right? I think for blue light, there's a lot of publications from the registry and that, but really the wheelhouse is in detecting superficial lesions on CIS. Mm-hmm. Sometimes I have patients ask, "Oh, well, then you can see if the tumor's in the muscle better." Not really. The mechanism of action for cis-view, and you could see why someone would think that, right? Because it's certainly a totally reasonable question, is that when you give the cis-view agent, it really is absorbed in surface urothelium. It doesn't have a deep tissue penetration, mm-hmm. at least as it is right now. And so I'm mainly looking for little small tumors that sometimes escape detection on white light. And I'm also really looking for carcinoma in situ that may impact risk stratification. And, trying to clear all visible things on blue and white light. But yes, I would say still got to do that repeat resection for the indications we talked about earlier.
Great. Are there any questions from the audience? Please feel free to come up and use the microphone.
In the meanwhile, there is one question, another one in the chat we can post. It's, can you please comment on high-grade T1 diverticular tumors in elderly patients? So I'll make my comment and the rest of the panel, but I think if the patient's fit for surgery, even though they're elderly, a partial cystectomy is probably the way to go in a patient like that, in a diverticulum. Obviously, it's hard to resect, and the risk of perforation is high, but I think a partial cystectomy is what most of us would do. Now, if anesthesia says absolutely no way you can't do surgery in them, that becomes more challenging. And I think, similar to what we do guidelines-based, complete resection as safely and best as possible, and then intravesical therapy of your choice. I don't know if anybody else has any.
Agreed.
I just had a question for Dr. Porton. On I think it was your slides, it said monopolar. Is there a preference, monopolar, bipolar? Does it matter?
Oh, yeah, I think that was brought up to bring that up. I was trying to remember why I did monopolar there. I tend to do monopolar if it starts bleeding a lot. I feel like the coag capability is better. And one of my partners loves coming in my OR and being like, "Oh, it would bleed less if you did monopolar instead of bipolar." I primarily use bipolar resection. I like the control, and I feel like it destroys the tissue less. Meaning, what I can send to pathology is a little more robust. I think this is now where en bloc is kind of interesting for the select set of tumors. Because I think part of our limitations with pathology are from what happens to the tissue. I mean, we send it unoriented in a bunch of chunks and half of it's black. It makes it, and then we get really upset when they don't see muscle in there. But in that situation, it makes it a little hard. So, but yes, I do use bipolar primarily. And I do feel like I get less obturator reflex with bipolar, or I can control that better.
And
But
then,
I will switch to monopolar.
And then just quickly, if you see like a wide mouth diverticulum and there's multiple tumors, they look papillary, they're small, but you're afraid you're going to stick your loop in there and you may perforate the diverticulum. What's your management of those for anybody?
I think ablation, in that situation, if you're headed towards a partial cystectomy and you know that you've gotten enough tissue to make a diagnosis, then you can just ablate or vaporize the rest of the tumors. I don't tend to leave things behind if possible, even though you're going to do an operation. And I would just stress imaging in those patients. We've been pretty impressed with multi-parametric MRI. A lot of those people are understaged. When you have high volume diverticular disease, they actually have T3 disease when your biopsy says they have T1 disease.
Thanks.
And to that end, not necessarily advocating for it in this case, but there is some retrospective data that I think John Sfakianos has published or presented on using mitomycin alone, traditional mitomycin, in a sort of chemoablative effect for some of those tumors, where you, just like with the Olympus and the UGN 102 trials, where you put the chemo in, you leave the tumor there, and it will ablate some of those, probably more for low grade, not for these bigger bulky tumors, but that's a potential option too if they can't get surgery.
It is very much surgeon preference, though. It has been studied as bipolar better than monopolar. And getting back to my earlier soapbox about TURBT, like if you're comfortable sitting, sit. If you're comfortable standing, stand. If you like the monopolar, use the monopolar. I would say have familiarity with your equipment. Know that, maybe this patient does need to be a little bit deeper because of obturator reflex. If you have a lateral tumor and you're choosing to use monopolar, if you're using monopolar and you're worried about cautery, make sure you're taking some cold cut biopsies at the base, which I think many of us do, so you have a good specimen with muscle in it that's not cauterized. I prefer monopolar personally, but I think it's very much your comfort. Yeah, we are getting the hook, so we'll have one more question, please.
Oh, it's just more of a comment. I'm a nurse practitioner and I work at a VA, and I've managed BCG for 13 years and I'm about ready to retire. What I would have loved is to have the Art of BCG book, because I think we have a therapy that is a first-line therapy. Most patients don't tolerate it over time. I've managed to get some through the 3 years of maintenance, but the dropout rate is great. And to instill practical knowledge of what works as far as patients' comforts, of how to actually manage them to make this gold that we have that's in short supply work for those patients. So that's number one. It would be really wonderful to somehow have a resource. People used to say you could give rescue Cipro, you could do this or that. And also we have a lot of patients with aggressive prostate cancer that are going through BCG. Mm-hmm. And at what point, so we're trying to figure that ADT up until the point of 1 year maintenance and then do treatment for that. And to remember that the veteran population, if they were all exposed to Agent Orange, that's service compensation, a lot of money, and the PACT Act also. So think about your veteran patients that may not be going to the VA. But it's just been a privilege to work with these patients, really.
Yeah.
And on a high
Thanks.
I know. I love that. Thank you. All right. Appreciate y'all. Thank you for coming.
Thank you.